Good afternoon, everyone. I'm Dr. Shalini Kaneriya, and this is Dr. Marathe. We are physicians, concierge internal medicine physicians with Lifetime Internal Medicine in Herndon, Virginia. This is our town hall, virtual Zoom town hall, and today we are excited to talk about COVID-19 and any updates that are available to us. We have a guest speaker today. I'm going to let Dr. Marathe tell you about her.
So we're really excited and fortunate to have Dr. Prachi Ranade join us today. She's an experienced board-certified infectious disease physician. She's been working at Inova Fairfax Hospital for over 10 years. Last 5 years, she's been doing exclusively infectious disease work, and she also has an outpatient practice as well. Currently, she is the co-section chief of infectious disease at Inova Fairfax Hospital. So we are excited to have her share her expertise. We did a COVID town hall. I think it's been in late May, early June. So lots have changed since that time, and the economy's opening up, and we're seeing surges in cases in different parts of the country. So I think it was time that we revisit this topic and bring on an expert to help us navigate this. So Dr. Ranade, thank you so much for being here.
Great, thank you both. Can you all hear me okay?
Yes.
Okay, great, thanks, and welcome everyone. I'm going to talk briefly about COVID-19, the novel coronavirus. I want to dive a little bit into just the basics, but I know everyone's been reading about the diagnosis, the symptoms already, so I'm going to dive into a few more topics that might be a little bit more relevant given the economy and travel, et cetera, et cetera. So as you all know, COVID-19 is a coronavirus. It is called coronavirus because of these crowns that you see on top of the membrane of the virus. Looking at them from far away, those spikes look like crowns, and crown in Latin is corona, hence coronavirus. It has nothing to do with the beer company. There's other coronaviruses that have been popular in the media within the last decade. Of note is SARS and MERS, which are all the same family of coronaviruses as COVID. They're just different genuses. And that will become a little bit more important as we dive into the topics. So what I want to go into is some local cases, what the case count is locally, what we're doing for testing, what is serology testing, should you get it, where to get it, what treatment options are available at this point, inpatient and some outpatient. Should we reopen the schools, what that means for children, what that means for parents and teachers, and how we can make that safe, and what Fairfax County is planning, and what to do in the fall and winter when we have influenza along with coronavirus, and how the influenza season is going to make things a lot more confusing, complicated, and a little bit more difficult for patients and their physicians. So like I mentioned, coronavirus is the same family as SARS, which is severe acute respiratory syndrome, which pretty much ravaged China and Taiwan a few years ago. And it's the same family as MERS, which is Middle Eastern Respiratory Syndrome, which was causing issues in the Middle East a few years ago as well. They're both coronaviruses, just different genuses. The reason this is important and may help understand why the world has been reacting in such a confusing way to this virus, to COVID, is that they're very similar. COVID, SARS, MERS are similar, but also very different. So in some sense, we thought it would be similar to SARS, so we implemented some measures. But as the summer and spring went on, we realized it was a very different beast than what we were used to and expecting. The coronaviruses only infect mammals and birds. Initially, they thought that coronavirus was from a wet market due to bat meat. And if you can see the camel on the picture, that is where they thought MERS came from. So it doesn't infect any other type of species, but mammals and bats. So this is the epidemic curve for COVID in Virginia this year. As you can see, in February and March, there were very few cases. Fairfax Hospital didn't have a case until early March. And so at that point, the country and our area, we weren't too concerned. We really didn't know what to make of it at this point. But as you can see, in March and April, things changed dramatically. The number of cases went up, and as did the resources in the hospital were limited. We really weren't sure where the peak would be. And thankfully now in July, the number of cases have come down dramatically, but they're not zero yet. And the important thing is that we must wait a few weeks to see where this curve is going to go. Is it going to flatten? Is it going to come down? Is it going to go up? No one really knows. Everyone has an opinion, but no one has a definite answer. So we have to just wait and see. And the reason we have to wait a few weeks is that it can take 2 weeks for symptoms to occur. So if you've been infected, it could take up to 10 to 14 days to feel the symptoms and start getting sick. And during that time, you are contagious. So again, this is just talking more about the demographic spread of coronavirus in Virginia. In Fairfax and Fair Oaks Hospital, the majority of patients that I treated were either Hispanic or elderly patients, one of the two populations. Initially, it was mostly elderly patients that I saw coming from nursing homes. And later on, it turned into mostly Hispanic patients. And on the left-hand side graph, you can see the cases by age in Virginia. I think a lot of people were aware of the fact that elderly patients, and by elderly, I mean above the age of 65, so please don't take that personally, but above the age of 65 or 60, people were aware that the infection risk is high and the mortality is even higher, up to 30% in some groups. And I think that elderly patients really took this warning to heart, and they stayed home and they socially isolated themselves. So the number of cases in Virginia, as you can see, are mostly 20s, 30s, 40s, and some 50s. Because I think that group did not socially isolate as well as the elderly patients. And within that group, the majority of people that we saw were Hispanic. And there are multiple reasons for that. The second group was also African American, but the population of patients that we see at Fairfax and Fair Oaks are less so African American and more so Hispanic and white. The reason that I feel and other physicians in the area feel that the Hispanic population got hit so hard doesn't have anything to do with a genetic predisposition as far as we're aware. It has more to do with socioeconomic disparities. Number one being many of the Hispanic patients didn't have the option of working from home. They didn't have the luxury or even the resources to have telecommuting or work from home. The jobs that they do or did were involved restaurants, retail, or construction. And as you know, it's impossible to work from home in those situations. So for them, it was either go to work, risk getting COVID, or stay at home and not eat. And it literally came down to those two situations. So they chose to go to work. And when they went to work, they used public transportation. That will put you at a much higher risk for getting coronavirus if you're stuck in the subway or stuck on a bus with the windows closed with someone else who's sick. So given that, we saw many Hispanic patients, and we would see clusters in families. So one day a father would come in his 40s, healthy, but severely ill. And then 3 days later, we would see his wife come in. Then maybe 5 days later, we'd see a grandparent. And then a week later, we'd see other family members. Because many of them stay in close quarters, either 6, 7, 8 to a 2 to 3 bedroom apartment, making social isolation impossible. And it really ravaged families. And there was a lot of discordance between the couples in the sense that one person, like the father, would get sick and not survive, but the wife would. And that was really very difficult to treat and to see. So I think that's the major reason why Hispanics and African Americans in our area were hit so hard. The reason the elderly patients were hit are mostly because they were white and they were from nursing homes. And as you know, the nursing homes in this area, and especially Richmond, were hit very hard with coronavirus and very early. We're seeing less and less nursing home patients come in positive for COVID, but it's not zero yet. So this partially explains kind of the demographic spread in this area. This just shows where in Virginia the number of cases of COVID have been. And as you can see towards the top right is most of the counties who are closer to District of Columbia, where it's a little bit more crowded, more populated, more people commute to work, either across the Maryland or DC state border, exposing themselves to more people, and thus the number of cases are higher. So I want to dive in just a little bit into the spread of coronavirus. How do you get it? And I think this is important because it'll help you understand how to protect yourself. If you understand how you get the virus, then making protection will be a lot easier. So number one, you've all heard of this, is it aerosolized, is it droplet? What is the difference? And it basically comes down to the size of the virus droplets, which are just a clump of viruses in your own cells. When the virus droplets are quite heavy, they don't travel as far. So they won't go more than 6 feet. And hence it's called droplet spread, which means if you're in a room with someone and they may be about 10, 15 feet away, the chance of you giving them coronavirus is lower. It's not zero, but it's lower. What happens when the virus is aerosolized? And in the last 2-3 days, there have been a few articles saying that maybe this virus is actually much more aerosolized than we initially thought, which will dramatically change reopenings. But as far as I know, for now, we're considering it a majority droplet spread. What is aerosolization? Aerosolization means that the droplets are smaller in diameter, which means they're lighter and they can travel further. So they can go up to 7, 8, 9 feet because they stay in the air a lot longer and can be spread. That happens when someone is coughing and they don't have a mask, or they have a mask that's not well covered. The particles go into the air and they just disperse. That also happens when someone is potentially talking very loudly or singing. They could aerosolize because it all comes down to the vocal cords kind of helping it dissipate. Other situations where where practices will aerosolize the particles are if you're on a nebulizer machine, where some patients with COPD may be using them at home, or if you're in the hospital and you're intubated, if you're going through an endoscopy procedure such as a transesophageal echo, or you need an endoscopy for a GI procedure. These are all things that will make the particles aerosolize, will make them more infectious, and that changes for the hospitals what PPE will use and we will need to use when we see these patients. What it will change for the public is that if this virus is more aerosolized than we initially thought, that means being in an indoor setting is really not as safe as we thought it would be, even with the right protection. So I think it's important for us to kind of take a look at the research on what it means to be aerosolized and if coronavirus is more aerosolized than we initially thought, because that will influence what happens in the fall and winter. But as of now, we're thinking it's droplet for the majority. So if you are outside but within 6 feet, wear a mask. If you're inside, wear a mask and try not to be inside with anyone who has COVID, in all honesty. Basically what happens is, let's say someone decides to go to the restaurants because they are open, and I'll go into what phase 3 means for Virginia towards the end of my lecture. But if you're in a restaurant and you're eating, you need to take your mask off. Let's say you have coronavirus and you're not sure you have it yet, you don't know you have it, you're asymptomatic, who knows? And you start coughing because you drank water a little too quickly and you forget to put your mask on. Even though other people may be more than 6 feet away from you, those particles will linger in the air up to 2 to 3 hours in the restaurant itself. So is it safe to go to dinner or lunch inside of a restaurant? I would say no, in my opinion. I'm not going to do it, and I'm not having any of my family members do it. Because even though everyone's got masks on, those particles can stay stagnant in the air for a few hours. Second thing is, well, let's say I want to go out for dinner, but I want to sit outside. I think that's fine if you have a couple things that you keep in mind to keep yourself safe. Number one is it's very airy. There aren't a lot of people around, and you have distance between you and another table. Number two, you don't get waited on. You have something that's takeout, and you sit down, bring the food to yourself, and eat amongst yourselves. The reason I'm saying this is because the third way that you can get coronavirus is through fomites. And fomites are any virus particles that live on inanimate objects or surfaces. such as copper. It's known that this virus in one study can live on a copper surface for up to 4 hours, can live on cardboard for up to 24 hours. So all those pizza delivery carriers and takeout pizza, something to think about how carefully you handle those boxes and how frequently you wash your hands. And stainless steel and plastic, in one study, it's known to live on that surface for up to 3 days. So what does it mean? Does this mean that we just sit at home, don't go outside, completely resign ourselves to a life in our apartment? No, it just means you really, once you understand how this is spread, you can keep yourself as safe as you can. Number one thing is, if you're outside, wear a mask. If you and other people around you are wearing a mask, then the risk of transmission is quite low. When you go outside and you want to get, let's say, takeout pizza, just because everyone loves pizza, bring in the box, take the pizza or whatever food outside of those containers right away, put it in your own personal container, throw that container away, wash your hands religiously, very well, thoroughly. And what I also do is I wash my nose and mouth. It's just extra measures to keep yourself safe. Some people have said, should we change our clothes? Should we wash our hair? Should we change our shoes? What should we do? I think we have to perform measures that will be sustainable and something that we can keep doing for weeks and months on end, because this is not going to go away anytime soon. So extreme measures, we will be fatigued and we'll stop doing it and we'll miss something. But something more sustainable, like washing your hands, washing your face, throwing away containers that are from outside, I think is something that we can keep doing for weeks or months if we need to.
Actually, can we ask you a question?
Yes, go ahead.
So there was a question about running or exercising outside.
Mm-hmm.
And, I think a lot of us are trying to, entertain ourselves outside either by running or hiking or biking. And, we try to cross the street if somebody is, right next to us, but sometimes it's difficult to. So
Right.
I asked a question here saying, sometimes people don't move 6 feet away and they don't wear masks. And so she tries to pull her mask up and tries to move away. So what do you recommend for people outside in terms of distance and socially and mask wearing? So, we see sort of the whole gamut. So I'd love to hear
Right.
you.
No, and I think it's the summertime. People need to keep themselves sane, and that involves being active and getting outside your house or apartment. So this kind of alludes to the risk factors of who is at risk for getting sick from COVID. Number one is obesity. Along with age, obesity really puts you at risk. So then you're going to say, well, Dr. Ranade, you told me I need to lose weight so I don't get sick from COVID. Yes, well, where are you going to lose weight? You can't go to the gym. So I do recommend exercising outside if it's an open environment. If there are about a lot of people packed into a small space, even though it's open, I would say avoid that. But if you're going for a walk, going for a run, it's the risk of getting COVID outside is very minimal, with or without a mask, if you're briefly just passing someone on the street. What I do personally is if I go for a walk, I will take a mask with me. And if I feel like I'm getting to an area where there are a lot of people mingling about, then I just put it on and I leave it on for at least 5 to 10 yards after I pass those people. Because as I mentioned, they can the particles can linger in the air. If I'm going for a run, I can't wear a mask. It's just impossible. So I think you have to just be a little wary when it comes to staying in close quarters, even if it's outside. But if you're passing people briefly on the street, I think it's fine. And I think at least in Falls Church, what I've noticed is a lot of people are going for a walk. They're trying to stay active, and no one takes it personally if you cross the street to avoid being close to someone. Everyone's doing that, and I think that is the safest way to go. But if you can't and you have to pass someone directly on the street, it's okay, because the risk of getting COVID briefly from a brief transition like that in open air is very, very low. So I think exercising outside is fine. Going for a walk outside is fine.
Do you have any advice on the best mask material for cloth masks? Or really, what we've just said to people is wear a mask, right? Like, don't obsess over whether it has a filter or how thick it is. Make sure you can tolerate wearing it. So there's a question on that. And if you could talk to reusing PPE, some patient has asked if he puts the mask in a bag in a garage for a week, could he use it again? So just if you could speak to questions.
Yeah, I mean, people are going to run out of masks if we don't use them judiciously. But at the same time, not so much. So a couple of things. If you're doing day-to-day things like going for a walk, running errands, going to the grocery store, the risk is a little bit lower from getting COVID because you're not exposed as much. So for that scenario, I think a cloth mask of any kind is fine. But the number one thing to keep in mind is if the mask is wet or soiled, then that defeats the purpose and it makes it less, it's much more likely for it to be more breathable, and you can easily transmit virus a lot easier that way. So if you are going to use a cloth mask, which is what I use when I don't go to work and I'm doing errands, is I don't reuse it unless I wash it and I dry it. And it's just a regular wash, dry cycle in not dishwasher, laundry. You don't have to do anything special. But if it's wet or it's soiled, you have to replace it right away because then it loses its effectiveness. Secondly, you can buy all these fancy masks that you see on Amazon, but I don't know if they're OSHA approved. I don't know who's vetted them to see, hey, is this really an N95? Is it something else? So I would say the best case is to buy a cloth mask. Don't let it get soiled or wet. If it does, replace it and wash it after each use. If you're going to go on a plane, that will change the situation dramatically. Do you want me to talk about that now, or do you have another question I can answer?
I'm sorry, Dr. Ranade. What did you say you wanted to talk about now? Sorry.
So I think, doing regular errands, going to the grocery store, stuff like that, a cloth mask is fine. But if you are thinking of traveling and getting on a train, taking public transportation, or going on a plane, that would change the tactics I would use. The reason being, and I think the reason being is that the most likely way of getting COVID is through mucous membranes, such as mouth, pharynx, and also eyes. There hasn't been a case documented that someone has got COVID purely from their eyes, but it is theoretically possible because it's a mucous membrane. So if someone coughs, you have a mask on, but you don't have eye protection in, potentially you could get COVID that way. So I would say if you're going to be in close quarters with the public, such as an airplane or a train, public transportation, if it's a bus that's not ventilated with open windows, I would use a mask, and I would even recommend using a face shield where you have your mucous membranes covered, so the risk of contaminating them through virus particles is a lot lower.
Thank you, thank you. And I think we'll talk about back to school and
travel later.
I think we'll touch on that later. I just had one comment about the masks. I see a lot of people wearing masks with their nose out. You have a nose, that's one thing. And then I have heard that the bandana masks, which is not really a mask at all, where you just put a bandana and you tie it behind and it's kind of open on the sides, is almost of no value. So a mask really has to be a mask where it has to have a little bit of a seal on the sides. So other than that, I mean, homemade masks are fine. You know, you don't spend a lot of money. There's all tutorials online for just cutting fabric and no-sew. You want to make your own masks. So those are my just two comments about the mask wearing.
And I wanted to say one more thing that, I know it's hard to wear a mask. I understand that, but there are, we see a lot of patients, and I've seen so many people that have COPD and asthma, and they are managing to keep that mask on. And so I try my best not to complain about it. And I know it's frustrating, and you have a moment, you can get outside and take it off, right? You don't see anybody. But do your best. It makes everyone feel more comfortable when you're wearing a mask, because we're all scared. We all, have that kind of paranoia that we might get it. And so I think it just helps, allay everyone's fears if they see others in a mask.
Completely agreed. And I think it really comes down to just habit formation. And I wear a mask when I go to work for about 8 to 10 hours a day. You get used to it. Am I saying that it's comfortable? Am I saying that I love it? No, it's just something that you have to do. And once you realize you have to do it, it becomes a lot easier. And I agree, any kind of mask is okay as long as it's got a good seal over your mucous membranes. And what mucous membranes are: mouth, throat, and nose. You have to cover this area so that it's not exposed to the outside. And if you cough and there's opening down here, the cough and the virus will go any which way it has an opening, the easiest way for it to go. So exactly like you said, cover this area very well. And a face shield, if you're going to be exposed for a long time, first of all, I'm not planning on getting on a plane until January at the earliest. And I love traveling, but I'm pretty much resigned to not getting on a plane for a while. And even a train or public transportation, I'm avoiding it unless I have to. But if you have to, I know there's certain situations where you have to go. And then I would say wear a mask. If it gets soiled, take another one with you so you can replace it, and have a face shield so you're covering your mucous membranes appropriately. Wash your hands vigorously and thoroughly, frequently. You can use the alcohol gels as well, but you basically want to protect your mucous membranes to the environment. And even just you touching your face, try to avoid that. I know it's hard, but work on that. I think someone had a question about swimming pools and is that safe? So I don't think coronavirus is transmitted through water. I think it's more important that the swimming pool is not busy and people are just going to swim laps, and there's one person in the lap lane, so you're still able to maintain some level of distance from the swimmer next to you. I think it's safe as long as you also avoid many people in the bathroom. So it just comes down to, again, droplet exposure. If you are in close quarters in a swimming pool, everyone comes up for air, and that you can't wear a mask in a swimming pool. So it's okay to go swim and have it be safe if there are not a lot of people there when you're there at the same time.
Great.
The other question, I know someone asked me the other day about public bathrooms. I went to a winery actually earlier today, because it's my day off, and I was in the bathroom. I had to go wash my hands, and I saw that there were 3 stalls. The middle one was blocked off, and the 2 side stalls were open. And I thought that was interesting because while you are maintaining social distancing when you're in the stall, when you come out, there's no social distancing. You know, you still have to wash your hands at 2 sinks that are very close. The other thing that comes up is there are ways to identify coronavirus in someone's stool, in the feces. You do excrete it. Can you get it from fecal material? Not unless you have fecal to oral contact of some sort. So again, that comes down to going to the bathroom and washing your hands. And also, if you are using someone else's bathroom, and I'm going to get a little gross here, but let's say someone else goes to the bathroom for number 2 and they've flushed, and then you have to go. Then there is theoretically the possibility of aerosolizing that fecal matter that might still be in the toilet and you inhaling it after they flush the toilet, if that makes sense. So the safest thing to do is to, if there is a bathroom where you can shut the lid when you're flushing it so that there's no risk of aerosolization. And as always, wash your hands, wash your hands, wash your hands. So is it safe to use a public bathroom? Not 100%, but the way to make it safe is to not be in there when other people are in there. And if there's a way to close the toilet seat, to do that when you're flushing. Any other questions on kind of transmission, how to keep yourself safe out in the community?
No, again, I don't know if you're going to touch on this, and feel free to delay this question for later, and Ira and I, Dr. Marathe and I, talked about surgery, outpatient surgery, and whether it should be delayed. And at the time that we talked about it, I think we were just in phase 2, just entering phase 2. And we had sort of, you should delay it if it's non-urgent, if it's elective, but realize that everyone is trying their best to be safe, and the emergency room, if you need to go, you don't want to delay getting medical care. You mentioned something about aerosolization and general anesthesia, things like that. I just want to get a sense for you, many patients, it's been going on now from February, March until it's almost 6 months, right? So people do for things. And so I want to get a sense from you what your advice is. I mean, if a patient needs to get a colonoscopy and they had, many polyps and they're due this year, what would you recommend? And the dentist.
I would recommend going to get care, especially in Virginia, and I can only really speak to Virginia right now, is if you have to get medical care that will help you stay healthy in the future, such as dental work, such as colonoscopies or endoscopies, pap smears, mammogram, get them done. Because we've delayed long enough, and there's going to be there actually was a study that came out of, I thought it was Australia that said that the cancer risk has gone up because people are not getting their appropriate screening because of COVID. They're too scared to either go to the ER or the facilities are just not open. So now in Virginia, phase 3 is opened up. The number of COVID cases in Fairfax County is 1% or less of the population. So it is a lot safer to go out and get the usual things you need to get done. So I would not delay it any further. In fact, the risk to your dentist is a lot higher than the risk to yourself in dental work.
Yes.
So obviously, if you've been exposed to someone with COVID and you are worried that you may have it, then in that situation, I would say no, quarantine yourself. But if that risk is not there, then get your usual medical dental work done, because what we're going to also see, and this research will be interesting, will come out in a few years, is the secondary and tertiary complications of COVID onto the medical and the medical system are the number of heart attacks have gone up because people have waited to go to the emergency room. And the complications that come from those heart attacks have also gone up because they just waited too long because they were too afraid of getting COVID. The same goes along with strokes. The number of strokes have gone up in Virginia in the last few months. They're not sure if it's because of lack of access, the fear that people have of getting medical care if they feel the symptoms are coming on. But I do agree, go get the care you need. This is the time to open up and go get that done.
Yeah, I almost feel like going into a medical facility is safer than going to a restaurant perhaps, or a public bathroom. You know what I mean? Because medical facilities that have opened up with precautions in place. With
they were never closed, right? They were never closed many times, right?
Sometimes, yeah. But even the ones that were closed and then are opening, I feel like they're really taking great precautions for their patients themselves, their staff. Everything is cleaned so well. There's not going to be more than one patient usually. And so I feel like if you need it done, and we had some ER docs come on for one of our town halls, and really felt very confident after that town hall that the ER is a very safe place to be. If you need to be in the ER, you need to go to the ER as a patient, I'm saying, and that there's very little to no risk of acquiring COVID in that setting. So we want to just reassure our patients that they can get what they need.
Absolutely.
Completely. And there's been no cases of acquiring COVID if you've been admitted to the hospital from other people in the hospital. Everyone is wearing a mask, at least at the Inova facilities. Everyone is wearing a mask, and oftentimes we're also implementing a face covering or a face shield of some sort when we're dealing with patients one-on-one. When the patients have to be transported to other rooms, they have a mask on. In the ER, everyone has a mask. So I actually feel much safer in the hospital, ironically, than anywhere outside. And the number of healthcare workers that have been infected with COVID is not very high at all. And we're not even sure if those people got infected in the hospital or they got infected on the outside. So yes, get care if you need it. Even the ER, I was just down there last week. It is it's very safe right now. Yeah.
Thank you.
All right, let's go on to the next slide. So like I said, a couple points as to how coronavirus works and how people get sick will help you keep yourself safe. Number one, like I mentioned, is the transmission. How you get coronavirus, you only get it from someone else. And once you understand that, you can keep yourself fully safe. And what happens when you get it? Which way are you going to go? So this slide explains a little bit as to how coronavirus works and who gets sick, who may not get sick. So day 0 is when, let's say, you're exposed to someone who has coronavirus. It doesn't matter if that particular person knows they have it, if they have symptoms, if they feel fine. You've been exposed to in some way to someone with coronavirus. When are you contagious? This also comes back to why the medical community at large was so conflicted as to how to view this virus. It is the same family as MERS and SARS, like I mentioned earlier on, but the key difference is that it's a new virus. It's a novel virus, which means that humans have never seen it before. We don't know how our bodies are going to react to it. And this is a perfect example. Initially, we thought that coronavirus was only contagious when someone had symptoms of the infection, such as fever, cough, etc. What we've realized in the last few months is that you are contagious even without any symptoms, and you start becoming contagious 3 days before you even start having symptoms. So that is why it's so important to socially isolate, because you really don't know who has the virus, who's going to get sick from it, who's never going to get sick, because those people will still be infectious regardless of their symptom state or not. So this slide just explains that. You're exposed to the virus, you're infected, and you can go one of actually three ways. One is that you are exposed but never get infected, so you're fully healthy. Number two is you get exposed, you are infected, but you have no symptoms. You feel fine. You are fully managing and living your life like you've always done. You are still highly contagious. And in some case reports, I've read that you're sometimes even more contagious than if you have symptoms, purely because you don't know you have the symptoms, so you're not implementing the proper social isolating measures. And you start becoming contagious 3 days before you even begin to have symptoms, which is a subset of population. That means you could be sitting next to someone in a restaurant, they feel fine, you feel fine, but you have no idea which one of you actually has the coronavirus or not. And this is why it's made a big leap from SARS and MERS, which are a lot more deadlier. And the mortality for SARS is up to 50–70%, and for MERS it's been higher. But those two viruses can only be contagious if those patients are symptomatic. If those patients don't have symptoms, they cannot spread it. The difference with COVID is you can spread it at any time with or without symptoms. Then you're going to ask me, well, when am I not contagious? So according to the CDC website and WHO, it takes 10 days for you to stop becoming contagious from exposure. So like I said, if you don't know you're exposed, you have no symptoms, you have no idea when you're going to be contagious and when you're not. So you just assume everyone is contagious all the time. And that's why social isolation is so important. If you get sick from the virus, which can take anywhere from 3 to 2 weeks to develop symptoms, with the average being 3 to 5 days, you stop being contagious after 10 days of developing symptoms, or 3 days after your symptoms, including fevers, cough, respiratory symptoms, resolve, whichever comes later. Which means that if you got sick and you've been sick for about 21 days with a fever, with a sore throat, with cough, even though it's been past the 10-day mark, because you still have symptoms, you are still considered contagious and should continue to self-isolate. And that's a very important distinction that has been developed over the last few months from WHO and CDC, is that even if you have symptoms, you still are considered contagious. So then let's say you think you were exposed to someone with coronavirus. Let's say you went to the beach or went on vacation. You come back, you feel fine. It's been a couple weeks and you're like, hey, I want to know, do I have the virus? I'm not sure if I was exposed. I don't recommend getting tested for the virus, because you could still be, even if it's positive or negative, if you do or don't have if you have no symptoms, it shouldn't change anything. You should still self-isolate. But you're still curious and you're like, you know what, I was kind of a little sick in March, had a little bit of sore throat, fever, but I couldn't get tested because there weren't enough tests, whatever it is. And now it's July and I want to know. I want to know if I have the virus. I have a lot of questions. I have a few patients like this. And the one thing I can suggest is possibly getting an antibody test. And the reason I say possible is because it's still not 100% this test. So basically what antibodies are is that when you are exposed to a pathogen, such as a virus or a bacteria, your body fights it off and it builds a robust immune response. And the way it fights it is making proteins called antibodies, which latch onto the virus and physically fight it off. The antibodies can take up to 1 to 3 weeks for your body to produce them. And this is what we're trying to pick up when we talk about serology. We're talking about the antibodies or proteins that your body's produced to fight the infection. We recommend, if you are to get tested for antibodies, it can take up to 1 to 3 weeks to even get positive tests done from the antibodies, which means if you were sick, you should have been resolved by now. And in some cases, even though you know you had coronavirus, PCR positive, you were sick, you were in the hospital, you feel better now, we get your antibodies and they could be negative. It's either because your immune system wasn't as robust and didn't have an appropriate response, or you did build the antibodies, but they waned very quickly. So a lot of research still needs to be done. So I would honestly recommend, if you're feeling fine, you're not sick, don't get testing of any kind, just self-quarantine, because the tests are not 100% reliable. Any questions about this before I move on?
Prachi, so question for you about the isolation. You mentioned 10 days. So let's just say someone went to the beach. You know, a lot of kids are going to beach week or went to beach week. They come back, and would you say that they should quarantine for 2 weeks or 10 days or 1 week? I want to understand that.
So I would say don't go, number one. But if you must go, I would say at least 10 days. I think 10 days is what the CDC was saying. 2 weeks, we say 2 weeks because it's just an easier number to remember, but anywhere 10 days is the minimum. 3 days wouldn't be enough, but I would say 10 days because it can take about 10 days to even if you were infected, to develop symptoms and then to be symptom-free or infection-free.
Okay. And we do get a lot of questions about asymptomatic testing. And I know I've heard you, say that you're not recommending that. So suppose a person is not really able to self-quarantine for 10 days. You know what I mean? Like suppose they have to go to work and they care, they're caregiver for somebody. There are situations that people want to know. And so if we were to swab them, could we rely on that negative result to assure the patient that they are not going to infect who it is that they are going to be around if they're not able to quarantine?
No. And I think I might have that in my next couple slides.
Okay, sorry, I didn't mean to.
No, this is a good question. So let me actually just move on to this and then we can talk about that. So no, I think it's a good question. So how do we test people for COVID? Right now, the test that we're using is called a PCR. It's basically a fancy term that basically means if you have the virus, we have to amplify it in the lab because the virus is very small, microscopic, and we won't pick up a very microscopic virus without amplifying it 1,000, 1,000,000 times, and then we can actually see the virus and identify it. So that's all that the PCR is. And we obtain it by either doing a nasopharyngeal swab, which feels like a brain biopsy, I've been told. But you basically have to stick the swab high enough into the pharynx, so it's pretty high, so you get a good sample. The other way to do it is either a sputum collection, which right now in Inova we're not doing, but other facilities and other hospitals around the country are. The third way to do it is a throat swab, which is not as sensitive, so I don't recommend that. And finally, to do a bronchoalveolar lavage, which is only going to happen if you're in the hospital. So what you're going to see is, let's say you want to get tested for COVID. They're going to do a PCR, and they're going to stick the swab in your nose pretty deep to get a sample and look for the viral DNA. That's what we're looking for. The sensitivity of that has been reported anywhere from 70 to 98%, which means that there's about 2 to 30% false negative rates. So let's say you have no symptoms, but you're going to take care of someone else, like an elderly patient or a family member, and you want to know if you have COVID. You can get the PCR, but a negative result is not enough to say that you don't have coronavirus because it could be a false negative. So what we do in the hospital is if you are symptomatic and you have fevers and chills and we're pretty highly suspicious you have COVID and the first test is negative, we repeat it with a second test. And let's say you're just negative 3-4 times. And I would never subject someone to this many COVID tests in a row because they're very painful. But if we feel that you have COVID and the tests come back negative, I don't care. We still treat you as if you have COVID, if you have the symptoms.
Right.
Because the test is not 100%, it's closer to 70%. But let's say you have no symptoms and you really are not sure and you just want to protect the people that you're close to. You can get a test, and if it's negative, I wouldn't keep repeating the test because it's just not a great test to begin with. Instead, I would say use the proper protection. If you're going to take care of someone, gloves, hand washing, face shield, mask, all of that, and maybe even put a mask on the person you're taking care of to double protect both of you. But repeat testing at this point, the tests are just not good enough to kind of suggest that right now.
Okay, great. And the yield on the test, I would think the sensitivity would be higher in someone who's symptomatic. So if you're asymptomatic, you're just likely not going to be generating as much secretions. There's not going to be as much viral load for you to actually get with the swab. But it's so for asymptomatics, I feel like then I really just don't know what to do with that result in terms of reassuring people. So so we should be able to tell them, it's not a negative test, don't be reassured, right?
Yeah, don't be reassured, still socially isolate, be as safe as you can. But the only reason that might be of importance is if the test is positive. Then you know for sure, hey, you have COVID, don't go stay at home. But you're right, it wouldn't change what you do if it's negative. And the sensitivity of the positivity of the test really relies on a few things. Number one is the quality of whoever's taking a sample. So in my slide from before, these were just some of the facilities you can go to get COVID testing if you have symptoms. And at the bottom, you see that you can get testing done at CVS and Walmart, but they're self-tests, which means that the swab that you see here, you're sticking that up your nose yourself. And most people that I know, they don't stick it up far enough because it is very painful. So that will limit the availability of the virus that you have to amplify. So the test results will be probably negative even if you are infected. And also when during the course of your infection, it's important because the earlier we test people, the lower the risk of the test becoming positive. So let's say you got infected 3 days ago. You don't have symptoms yet, or maybe you'll never get symptoms. The chance of you being positive that early is a lot lower than if you wait a few more days to get tested. So the timing of the test depends, how sick you are, it depends, how the test is obtained depends as well. So there are a lot of variables. Some of the other tests that we're using now is called an ID now, which is still a PCR. The science is still the same, but it's a lot more rapid. Turnaround time is around 2 hours. And this is the test that a lot of the hospitals are using pre-procedures. So if you need to go and get your endoscopy or get your colonoscopy, they would require you to get this test a day or two before to make sure you're negative. It's much less sensitive. I think the sensitivity for ID now is anywhere from 30 to 70%. So if we were to get that test, but we're still very suspicious, then we always revert to the PCR as our final test. An antigen test basically picks up the proteins that live on the top of the virus, and the CDC just released an adverb about having this test be available in the US, and we haven't started implementing it yet, so I'm not sure about the data for that test yet. And finally is serology. We're not using serology or antibody testing to diagnose someone with COVID. We're using it more as research purposes to say, hey, you've had it in the past, and your body is showing that it's reacted to it. But it means nothing. It does not mean that you're protected. It does not mean that you're immune. There are still case reports of people getting COVID twice. Not many, but that's still out there. So just getting antibody tested done and knowing that you're positive really doesn't mean anything, given that you still have to isolate, you still could get reinfected. So it's just more of curiosity purposes at this point. And then there's a viral culture, which is not developed yet. I'm hoping that Abbott or some other labs will develop that in the next few months. So any other questions about testing before we move on?
No.
Okay. All right, so finally we'll come to treatment, medications, and vaccines. So so the treatment strategies for COVID have changed dramatically in the last 3-4 months. I mean, I've never been in a situation where one day you do one thing and the next day you do something completely opposite. And that's pretty much what happened in April. In the beginning of the pandemic, there were case reports and articles from Italy and China that said intubating these patients or giving them steroids made them die, made them more sick, and it really increased the mortality. So we had shifted away from that during the initial phase of the pandemic in Virginia. But as April came along, we realized, you know what, steroids is actually, they're gonna help. Steroids suppress the immune system, and COVID is known to cause an overwhelming immune response. And if you suppress that immune response, it will help with the inflammation and the damage that that response does onto your organs. So we went from not giving steroids and being very scared of them to giving them early and giving them pretty much to almost anyone who required oxygen. The second treatment we had is remdesivir. It's an antiviral that was developed to treat Ebola, but it really didn't have good effect on Ebola. So they manufactured it to target more of coronavirus. And it works by actually being an antiviral, so it targets the virus, and it decreases the number of days you will require hospitalization and decreases the number of days you'll have a fever. I've personally seen a lot of improvement with my patients with remdesivir, but the data really doesn't show that it's got a huge cure rate, but it helps you get better quicker, if that makes sense. The third thing is convalescent plasma, and this kind of goes back to the antibody explanation I had earlier. If someone gets COVID, they get better, their body still produces these antibodies, and those antibodies will be used to treat other patients with COVID. So if you've had coronavirus and you have improved, I would recommend contacting Inova or the NIH and being enrolled in this trial where they test you for the antibodies. And if they're positive and they're robust, they'll take your plasma, which is your blood, extract the antibodies from it, and inject it into someone who's actively infected with COVID. And we've seen some very good responses to that. The fourth one is tocilizumab. It's an immune modulator that suppresses your immune system. It's not as promising as initially expected, but I just kept it on there because we do use it. And lastly, Plaquenil. I'm going to come back to that in 2 seconds. Let me just talk about some non-medication treatment strategies we've been using in the hospital. Number one is proning. What that means is these patients with COVID, they basically can't oxygenate their blood. They're suffocating in a way. And proning is where you lie flat on your stomach, and that helps oxygenate your blood and your organs easier. And we have patients who have issues with oxygenation or have low oxygen levels from COVID lie flat on their stomach for hours or days if they can. And that really helps them feel better and oxygenate better. The second thing is keeping patients dry. And what that means is we give them medications such as diuretics, Lasix, whatnot, to help them urinate frequently, to get rid of as much water they have in their bodies, to keep them dry, keep their lungs dry so the lungs can perform properly and oxygenate a lot better. So those are some of the non-medication treatments we've been using, along with the steroids and the remdesivir and the other ones I mentioned. This is mostly for patients who are sick enough that they require hospitalization. So far, I am personally not giving medicines to outpatients if they have COVID, because number one, they're not ill enough to be admitted, so it's their oxygen levels are not low, so they may not benefit from any of these, because a lot of these medications have shown benefit in patients who have low oxygen levels. There is a medicine called Marathe, which is an anti-HIV, antiretroviral, that study one of my partners is doing to see if that helps with COVID. He's been giving that more to outpatients, but in a very limited manner. So at this point, there isn't any treatment for COVID as an outpatient except for Tylenol, rest, the supportive care. Plaquenil, very hot topic. So in Inova, the last 1 month ago, we basically took Plaquenil off of our suggested medication list to treat COVID because we realized it really wasn't benefiting the patients, and there are a lot of side effects from this medicine. Not many people can take it. It has detrimental effects to the liver and can cause arrhythmias and other heart conditions. So if you are going to prescribe it, you have to get an EKG, hopefully daily, and monitor the patient really well to make sure they don't develop cardiac side effects. And also the benefit of Plaquenil is really questionable depending on what study you read. So at this point, Inova is not recommending using Plaquenil for treatment, and there really hasn't been any evidence, good evidence, to suggest that it can be used as a preventative measure. I know certain countries like Brazil, et cetera, are giving it to their army, but I personally would not take it, and I don't believe that it's causing a prophylactic effect. There's not enough data yet to subscribe that. So I wouldn't treat someone with that right now, especially when we have other medications like remdesivir, convalescent plasma that has shown a lot more promise. Vaccines. So I hate to be the bearer of bad news, but I really don't think there's going to be a vaccine this year. There may not even be one next year. Vaccines take a long time to produce and for them to actually be safe and work. The reason being is that initially, let's say they develop a vaccine in January. They'll give it to around 10,000, maybe 100,000 people. They'll have good effect. Maybe they'll see a few side effects, but not too many, so they deem it safe. Then they expand that trial and give it to 1 million people. And that's really when you'll see many of the side effects from these vaccines, is when you give it to a robust population, differing in demographics, age, etc., which is really what we'll need for this type of vaccine. It's going to have to target people of differing ages, comorbidities, etc. To develop a vaccine like this that's very safe for pretty much the whole world is not going to be easy. It's not going to be quick. And I don't care what the news says is not going to happen this year. And if it does, I'm not going to take it. It's just not going to be safe. Maybe next year, maybe the year after, but I really don't think it's going to be available this year. Now, along with it being safe and it being manageable, when do you take it? Do you take it every year? Do you take it once in your lifetime? The antibodies that we've seen to COVID wane after some time. So after a few months, they go away, which means in theory, your immunity to the infection is also gone. And that's how vaccines work. They basically give you a little dose of the virus, a dead virus usually, and they wait for your body to produce a robust immune response that will protect itself if you were to actually see the virus in the future. So what we're contemplating at this point is if they do have a vaccine, we probably will have to get it every year because that immunity will wane. So will they do it along with the influenza vaccine where you go every year and just get both vaccines? That's a possibility. So it really comes down to, is it going to be safe? How long is it going to work? How well is it going to work? Some people can't take vaccines. Will everyone have to take it? Who's going to get it first? And lastly, I mean, who's going to pay for it? There are so many unanswered questions right now with vaccines that I would not hold out hope for that. And I don't want to be the bearer of bad news, but that's just kind of where we are right now.
I just have 2 questions, and I think we're running, close to being out of time. I just wanted to ask 2 questions. For those of us that have been doing our best to socially isolate and and doing the right thing, I just want to get a sense of how resources are in Northern Virginia for some of these medications, and based on the hospital you're at. I know you're at Fairfax, but should patients feel reassured that if they're doing the right thing, and we all try to do our best to do the right thing, that there will be enough remdesivir or enough of these these medications? Or have you been in situations where patients cannot get these medicines?
Yeah, good question. So steroids will definitely be abundant because they've been around for a while, and I'm not worried about running out of those. The remdesivir, as of July 1st, it went commercial. So before July 1st, Fairfax actually had a huge shipment delivered to us. After July 1st, what will happen is if we have a robust supply and we're not using it because the numbers are dropping, then FEMA will actually come along and take some of these resources from us and ship it to other parts of the country who do need it. So I'm not worried about not having remdesivir at the moment. I was just in a meeting at Fairfax the other day with the financial lead, and basically it came down to, if you need it, we will get it. Now, who will pay for it now that it's commercial? There are a lot of resources that the hospital has. So I'm not worried about running out of remdesivir right now. What's going to happen, what concerns me more, is if there is a second peak and that peak is sustained, then at that point, I'm just not sure how quickly we'll be able to manufacture it down the road. Right now, I'm not worried. What's going to happen in September, October, I'm not really sure yet. Also, I think a very important question also is what happens with the PPE. We were running out of PPE 2-3 months ago at Inova, at the hospital. We were able to manufacture some. We had a company actually make us gowns from El Salvador, and we really used our resources. But if this second wave comes, because we're not even in our we haven't had a second wave yet, this is still the first wave. PPE is going to be a lot more concerning to me than the medicines, because that was really what will help prevent the spread. So I'm not worried right now, but I'm reevaluating my concern every month. Yeah. And I think that's where maybe Plaquenil may come more into favor is if we are running out of these usual medicines like remdesivir or plasma, then maybe Plaquenil will have more of an effect, or we'll have to use it more. So there's definitely options, and by no means are we going to turn away anyone because we don't have medicines. We will figure it out. It's just a matter of kind of how we do that. So I'm not worried right now.
You know, I think maybe we skip ahead just really to phase 3, because I do want you to talk to school reopening. I think that's a really big one. Many patients have, you know, children that are going back to school. And there's obviously, I don't know if you have children, but in Fairfax County versus Arlington County versus Loudoun County or private schools, you know, their kids are going to be subject to partial exposure, right? And so thinking about that as patients make their decisions, whether they want their kids to go to school or have fully distance learning, would love to hear a little bit about what you could speak to about that.
Sure. So right now, as I know in Fairfax, they are reopening the schools, but having it like 2 days a week. And it's really up to the parents if they want to bring them, and then they're going to be social distance, and the rest of the time is going to be home learning or telelearning. It concerns me. I don't have children. I have a nephew, and I have friends who have kids, family members who have children. Kids are not good at social. They're good at social distancing to an extent, and they're not really good at wearing masks. Mostly because it's annoying to wear a mask. So, and it's going to be hard to implement that. And at this point, I really don't know how they're going to do this safely. I think if they are to do it in a safe manner, I would test these children once every 3 to 4 days with a swab. That's what the National Baseball League is doing. They're testing their players every 3 days for COVID with nasal swabs, just to see if they pick up someone positive, they jump on it right away and isolate them. So that's one way to open up the schools and the daycares, is to test people frequently, religiously, and jump on a case if it's positive. But if they don't do that, I really don't see how they're going to make it fully safe. I think if the numbers go down and the number of people with COVID in Virginia are close to less than 0.5, 0.4%, the risk is a lot lower, and then that changes things. Then you can open up a little bit more safely. But at this point, currently, with the numbers being the way they are, I'm really not sure how they're going to do that. The caveat is that there's some studies showing that children are a lot less infectious, which means if they do get COVID, they don't get as sick, and they don't transmit it as easily to other people. So if children do get COVID or exposed, or the risk of them giving it to their family members and their parents is lower than the parents giving COVID to the kids. So that kind of influences things either. So it's a really hot topic. I'm not really sure kind of what to say about this yet. I'm a little unnerved that they are planning for sure to reopen. I think things may change in the next 3-4 weeks if the numbers go down or the numbers go up. So I think at this point, just let's see what happens in 3 or 4 weeks as the summer rolls to an end.
I mean, I think it's really difficult, as you said, you can say that you could swab them every 3 to 4 days, but in reality, that's sort of absurd. And I know you know that, right? It's hard enough to swab an adult. I can't imagine swabbing a child, right? So there's that. And then the realities of just, monitoring. I think, they were even deciding to decrease the distance to 3 feet, right? And so, I know the 6 feet is also quite arbitrary, right? Like 10 would be better, it's really 3 would not be. So I guess there's pressure from American Academy of Pediatrics to have children go back because of the stress and the trauma of just not being able. So I understand that there's a lot of conflicting kind of feelings towards that. But if you could just, I would love to hear from you about phase 3 and kind of where we should be concerned. And, love to hear, because I know a lot of people want to go back. They're going to be going back to work, and they're going to be, getting their hair done and those kinds of things. Is there anything to be aware of?
Yeah, so I think if you just, if people remember the slide that I had as to how you get COVID, right? If you are going to be in public, mask, potentially eye protection, and limit your exposure for as long as you can. So if you are going to go to work, if they should, every job should implement wear a mask policy. So if you see someone not wearing a mask, I think it's okay to say, look, do you mind wearing them, or don't be close to them, because that is really the only way to kind of prevent that. And to wash your hands. I leave like a little jug of hand sanitizer at my desk. Every computer has one at Fairfax, and I use that all the time. So those are the best ways to kind of limit your exposure to someone, or getting COVID in general. I think getting your hair done and things like that, it's a limited exposure. And if you're in the salon, there aren't many people, it's just you and the stylist and maybe one or two other people, the risk is a lot lower. I think it really just comes down to crowded areas. So if your salon has a ton of people waiting around, that's not the right time to go. Gyms, I'm really 50-50 about gyms. There was a report from Norway that said the risk of getting COVID at a gym was very low. But then there was a conflicting report, I think from Korea, saying that getting COVID at a gym was much, much higher. So the evidence is really, it's not clear cut. I believe the Korea report more than a Norway report, because there were a lot more cases of COVID in Korea. But I would say if you really want to go to the gym, make sure there are not a lot of people in there. Clean the machine before you use it and after, and get in and out. You know, this is not the time to dilly-dally, and do what you need to do away from other people. But in all honesty, I'm not going to the gym for a while. I'm going to work out outside. Beaches are safe. They're open as long as they're not crowded. Gatherings, I would say if it's an open environment, it's safer, but just beware of not touching things that other people are touching and just not being close to them. You know, it really just comes down to close contact and keeping your distance from people. Other things, I guess, other questions, overnight summer camps, looks like those are still going to be closed. Restaurants are open, and outdoor seating, I think, is much safer than indoor seating because of the reasons I mentioned about droplets in the air just sticking around. So phase 3 is not fully open. You can still do some things, but just be wary. Again, it comes down to not being around a lot of people. You know, stay away from strangers. I guess that lesson never goes away.
And it depends on your own personal risk. You know, if you're someone who would be likely to get very sick if you acquired COVID, then of course, even if phase 3 allows you to do things, that doesn't mean that you should do them. You know?
Exactly. Yeah, the elderly patients or people with comorbidities, something even as simple as obesity, it's been one of the highest risk factors of having a severe course of COVID, even more so in some cases than age. So if you're in that demographic where you're not, where you have these comorbidities, then I would even be double safe than someone who is not at risk. But that doesn't mean that you don't have other people in your life that you could get sick because of your exposure. But yes, limit your exposure. I wish I could say better. I wish I could say things are back to normal, but it's going to be more of a marathon rather than a sprint right now when it comes to keeping ourselves safe.
Thank you so much, Dr. Ranade. This was so informative. And I think, you know, we've been dealing with this now for 3-4 months with the lockdown, and people are getting a little tired, and they understandably wanting to interact. And I think we all needed a reminder about how serious this is. We're still in it. We're still going to be in it for a long time. So I really appreciate you sharing your expertise with us. I know that Dr. Kaneriya and I benefit from it. Our patients benefit from it. So thank you so much.
And thank you. Of course, if anyone has questions, they can reach out to me. And I think it's just, we're all in it together. You know, the whole world is in this together. And I think that gives me a little bit of solace that I'm not the only one dealing with it. We're all kind of have to, this is 2020, and hopefully 2021 will be better.
You know, there's just so much information to sift through. So it's really wonderful to hear your expertise and your guidance. And it's really helpful for us to know that we have you in our back pocket. So for your time, thank you for coming on and sharing this with our patients. And we will be posting a copy of our slides as well as any other information that is provided by Dr. Ranade on our website under the Video and Resources tab. And hopefully that will happen within 3 or 4 days of this presentation. As always, there will be a copy of this presentation on our website as well. Thank you again. Thanks, everyone. I hope
for next week.
Yeah. One more announcement for next week. We will not be having our town hall. We will send more information. It will be the week after next, and we will send you more information about that. So
Okay.
thank you
you
very
so
much.
much.
Bye-bye.
Thanks. Bye. Thank you.